And Dr. Mukesh Sarna also has joined in, sir. And Dr. Ashok Garg is already, he's on mute mode, but he has joined. Yeah, logged in. Yeah. Waiting for Dr. Balram Sharma only, sir. Just give me. Oh, right. Great, sir. Welcome, sir. Good evening. This is Rakesh Upadhyay.
कैसे हैं राकेश आप?
All well, sir. बढ़िया, sir. आप बताइए, sir. Thank you very much, sir, for sparing your valuable time.
All well.
चाची को दे दे मोबाइल, बोलना चाची कर लेगी वापस।
कैसे हो मनोज? वेल, कोविड पूरे पंप एंड शो के साथ आ गया वापस से। डॉक्टर मुकेश कैसे हैं आप?
चावला जी मैं आपको कॉल करूंगा अपने आप, थोड़ी देर रुको, एक बार मेरे कॉन्फ्रेंस
Yeah, Mr. Ankur, just
कैसे हैं आप डॉक्टर मुकेश?
Yes, tell me. बताइए.
Yeah. You put it on for our delegates,
Yeah. Just give me 1 minute.
No problem.
Maximum 1.
प्रदीप आप मॉर्निंग लेक में हैं प्रदीप?
हाँ सर।
कैसा चल रहा है, सब बढ़िया?
हाँ सर, बिल्कुल सर, एकदम ठीक। अभी तो कंडीशन थोड़ी क्रिटिकल है काफी।
हाँ, थोड़ी क्या पूरी हो गई अब तो खराब।
हाँ, पूरी हो गई है।
स्थितियाँ दिनों दिन बिगड़ती जा रही हैं।
सर हमने तो बंद कर दिया अभी, एक्चुअली ऑक्सीजन सप्लाई है नहीं तो पूरा ही बंद हो रहा है अब तो।
अच्छा, हॉस्पिटल ही बंद कर रहे हैं?
हॉस्पिटल तो बंद नहीं कर रहे सर, लेकिन पेशेंट जो है अभी उनको लेना था, नए पेशेंट तो ले नहीं रहे। जो पुराने पेशेंट्स हैं उनकी भी थोड़ी प्रॉब्लम है, तो हम तो शिफ्टिंग का उनको एडवाइस कर दिया अगर कहीं जाना चाहे तो।
नहीं, अब तो पेशेंट देखने का टाइम है नहीं, वैसे ऑनलाइन चला हुआ।
Rakesh ji, we are live.
Yeah, thank you. Yeah, Dr. Balram Sharma, sir. With your permission, sir, if you allow me, shall I start, sir?
Yeah, you can.
Yeah, thank you very much, sir. So, sir, on behalf of Welcome Laboratories, India's 5th largest pharmaceutical company, I, Rakesh Upadhyay, welcome our eminent doctors who have joined us for today's panel discussion titled Views on Vildagliptin. At Elkem, it has always been our endeavor to partner with healthcare professionals, and we will be continue to do so even in these challenging times. To help us navigate through the meeting, sir, we have with us today Dr. Balram Sharma, who will be our moderator for today's panel discussion. And I, on behalf of Welcome, take this opportunity to welcome Dr. Balram Sharma. Sir, I would just like to give a brief introduction of Dr. Balram Sharma, sir. He is a DM endocrinologist, professor and consultant endocrinologist, SMS Medical College and Hospital. He has got membership in American Endocrine Society, American Association of Clinical Endocrinologists Society, European Society of Endocrinology, Endocrine Society of India, lifetime member. He is an Indian Thyroid Society lifetime member and ISBMR lifetime member. And various awards into his credit, sir, like AV Gandhi Award for Excellence in Endocrinology and Outstanding Faculty Award by SMS Medical College, Jaipur. He has got many articles and theses published in various national and international journals. I would like to welcome, sir, for this views panel discussion.
Thank you, Rakesh.
Yeah, thank you very much, sir. And I would also like to introduce now our galaxy of panelists. We have with us on the platform Dr. Mukesh Sarna. Dr. Mukesh Sarna is a professor of medicine at Mahatma Gandhi Medical College in Jaipur, earlier associated with Fortis and Munilik Hospital, Jaipur. He has many papers published in reputed national and international journals, delivered lectures in various CMEs conferences, conducted several international clinical researches as principal investigator, and reviewer of international peer-reviewed journals, trained in health and hospital management as well. I welcome you, sir, for this program, sir. Dr. Mukesh Sarna is also a member of ADA API Indian Society of Critical Care Medicine, RSSDI. Welcome you, sir, for Global View panel discussion. We have Dr. Ashok Garg in the panelist, sir. He is in Jaipur Heart Institute, Jaipur. He is a member of Indian Academy of Echocardiography, API, CSI, International Society of and Ultrasound, American College of Physicians. Various special achievements into his credit, like first in the world to report pulmonary valve involvement, Loeffler's endocarditis, and co-organized Secretary World Congress of Echocardiography, Clinical Cardiology and Applied Imaging, October 2017, Jaipur, India. And welcome, sir, for this program. We have Dr. Manoj Kumar Khandelwal. He is a DNB Endo, consultant endocrinologist, Fortis Hospital, and ex-consultant Metro Mass, Jaipur and Medanta Medicity, Gurgaon. Also, he was associated with, member of ADA, and he's a DNB endocrinology and various observational study to evaluate the clinical and biochemical profile of Indian patients with primary hyperparathyroidism, and various paper presentation into his credit, sir, like SECON 2016, an observational study to evaluate the clinical and biochemical profile of Indian patients with primary hyperparathyroidism, sir. I welcome you, sir, for this views panel discussion. And we have Dr. Pradeep Jain in the board, sir. He is a senior consultant at Moni Lake Hospital, Jaipur, experienced physician with over 12 years of experience in general medicine, excellent reputation for resolving complicated cases, improving patient satisfaction, and driving overall case management. Senior medicine consultant and expert in standard and current ICU procedure, growth oriented and updated with current medical knowledge. With this, sir, not taking much time, I would like to hand over the session to Dr. Balram Sharma to please set the context and start the panel discussion. Over to you, sir. Thank you very much for giving up time, sir. Yeah.
Thank you, Rakesh. And thank you, LKM, for inviting me to this clinically very relevant and academically sound program. So good evening, everybody. During this tough time, this is really not practical and possible to meet face to face or to have any scientific discussion in the real world scenario. So for last few months, we are seeing that there is bombardment of a lot of scientific programs on Zoom meetings or other platforms. I know that many of you are also frequently attending these programs. Our audience might also be listening again and again these kind of programs. So I will try to keep it as crisp as possible, and I'll try to keep it as clinically relevant as possible. So I know that the vildagliptin is already that molecule which most of us and almost every clinician who is practicing diabetes is already familiar about. So the concept of incretin-based therapy started many years back. The incretin effect was actually first time came to the scientific knowledge in 1964, so long back. And that was the incretin effect, means the scientists were able to find the incretin effect only. But the evidences of incretin, GLP-1, then the DPP-4, the discoveries took little late, like a few decades later, the invention of DPP-4 story and the DPP-4 inhibition or degradation of GLP-1, native GLP-1 was recognized. And later on, after a few years, I can say that in late 2000, means in the last decade, that was the main time, like in 2007 or 8, when the introduction of these molecules came very rapidly, and later on in the last decade, these molecules actually established themselves as a clinically very relevant, clinically very competent, clinically very useful molecule with very sound proof of evidences, with lot of trials which not only established their glycemic efficacy, but later on the safety profile was also established in terms of the cardiovascular safety, except few molecules. But most of the molecules were established or they established themselves as a safe molecule in terms of the cardiovascular safety, in terms of the other safety. And I'm sure that initially there were few concerns about the risk of pancreatitis or about the risk of efficacy. But later on, every clinician, I'm sure that now they have very sound basis of knowledge, as well the clinical experience, that these molecules are excellent in terms of the efficacy, in terms of the safety, in terms of the affordability. That was main problem few years back. But now this particular problem is also sorted out with the available options, and we will be discussing almost all of these part of this discussion in coming few minutes. So you know that in the incretin-based therapy, we have various options ranging from the injectable to the oral. And as we know that in Indian setup, oral medications are always accepted and welcomed by not only the clinicians, but also by the patients. And that's why the oral molecules like DPP-4 inhibitors has established themselves excellently. Among the various options available to us, there are a lot of DPP4 inhibitors now available in our country. Also, we are practicing, we are using many of them. Vildagliptin is definitely among those molecules which is among the most commonly prescribed medication. And I'm sure that all of you are aware about the various aspects of vildagliptin, but here again, we will be discussing few clinically relevant points, few concerns that might be there in the mind of the clinicians, that when we should use it, when we should not use it, what are the added advantages of these medications. So these different spectrums we will be discussing. I'm sure that most of you are already aware about the Verify trial, which was one of the landmark trial. And that was a very long duration, more than 5-year duration trial, which actually established the confidence of the combination therapy right from the beginning. And I have a galaxy of speakers who are already established and well-known figures, and they are the icons of their field. Dr. Mukesh Sharma is there, who is professor from Mahatma Gandhi Medical College. Dr. Pradeep Jain is there from Moni Lake. My colleague, Dr. Manoj Kumar Khandelwal from Fortis Hospital, endocrinologist, and Dr. Garg from Jaipur Heart Institute. So we have a galaxy of panelists, and they will be sharing their own experience as well the scientific knowledge which is there in the literature in the crispy manner. So that will be useful to the audience, that this knowledge they can replicate in their own practice, in their clinical practice. And they need not to read more about the vildagliptin story now after this discussion. So we will be discussing about the Verify trial. We will be discussing about the available combinations of vildagliptin and how we can use them. We will be discussing some problem areas, like when the vildagliptin can be used, like in CKD patient, means special population patient, in special population like elderly patient, or in Ramadan patient, or in fasting patient. Also, we will be discussing few part. And in last, I will be discussing about the past patent era, means before patent and after patent, what are the differences. So we will be discussing about that. So to start with, I will come first of all to Dr. Mukesh. I'm sure that you are ready for your discussion, Dr. Mukesh. So I will request you to please enlighten us the knowledge of our audience about the Verify trial and how that is clinically relevant in clinical practice, and how that has changed the practice scenario or the hesitations which were there in the clinician's mind, that should we use combination therapy, shouldn't be used, should we start only with metformin, should we start with combination therapy, which combination. So these all answers will be dealt by Dr. Mukesh, and I'm sure that you will be benefited by that. Dr. Mukesh, over to you.
Thank you, Dr. Balaram. Our conventional understanding about diabetes was that we have to start the treatment with the basic treatment, preferably with metformin, and then to increase or to add stepwise the other drugs. So we started our practice like this only. But thanks to the different studies and different research, especially this Verify trial, which established the role of early addition of second OHA in addition to metformin, which proved that the initial failure of the treatment was less in the group where the combination has been given. So about this Verify trial, briefly I will summarize in 3-4 lines. This trial began in 2012 and completed in 2014. Almost they took 4,500 participants screened, and they took around 2,000 eligible participants. So this trial went for almost 5 years, and they made 2 arms. One is the metformin monotherapy arm, and the second is the early combination treatment arm. Almost the same number of treatments were there in both the arms, and they completed for 5-year study, and they found that the initial treatment failure during the period 1 was around 43.6% in combination treatment group and around 62.1% in monotherapy group. So the median observed time for treatment failure in monotherapy group was less. So that means that initial failure in these patients were high, and a significant reduction in relative risk was there in initial treatment failure. So early combination treatment arm was found to be good in comparison to the monotherapy arm in terms of initial treatment failure. So early, they interpreted that the early intervention with the combination therapy of vildagliptin plus metformin provides greater and durable long-term benefits in comparison to the current standard of care metformin monotherapy with patients in newly diagnosed type 2 diabetes mellitus. So this enlightened us that instead of starting with metformin and then subsequently adding other drugs, or preferably DPP4 inhibitors or incretin-based therapy, if we start with combination therapy, so the initial therapy, initial failure or the delayed failure, they are less in these patients. Almost 50% patient require, they fail in initial treatment almost in 3 years, and by next few years, they are almost 75% patient become basically fail in treatment response. So early combination therapy is now recommended depending on this verified trial, which has been published recently in 2019.
And the important point of Verify, I would like to add that, would you like to highlight about the HbA1c label of Verify, Dr. Sarna?
Yeah, HbA1c also in the initial treatment that did not maintain HbA1c below 7, while the combination arm maintained it. So the overall initial treatment failure was less in combination.
And in the inclusion criteria, that is also important. Most of the time, when we are dealing with those patients whose HbA1c is 6.5 to 7 or nearly 7, so many times, even I can share my views when I was doing my post-graduations, although the DPP4 inhibitors were not available there, but even in the DM endocrinology, in the initial part of DM training, we were hesitant in starting any combination. Once we were dealing with any patient who were having HbA1c in the range of 6.5 or to 7 or 7 point something so. And that was the main inclusion criteria of the Verify trial, that even in those group of the patient, they tried the combination therapy. So you should not hesitate using combination therapy even earlier. Means even in those patient whose HbA1c is not that bad. But if you are adding this type of combination therapy like vildagliptin plus metformin, which was used in Verify trial, they showed that that was not only the efficacy was better than the monotherapy arm, but the durability was also excellent. And those patient failure rate was less significantly less in comparison to the metformin alone arm. So even in those patients where HbA1c is pretty okay, you can even start the combination therapy. While before the Verify trial, most of us were hesitant in using combination therapy. Most of us were having the assumptions that only metformin is okay, and let it fail first, then we are going to add the combinations. So this concept has been changed by the Verify trial, that even if the things has not failed, you can start with combination, and the combination is going to provide excellent outcome because the duration was more than 5 years. So that is really excellent data to be shared. Excellently narrated, Dr. Sharna. Anything else would you like to add on? Otherwise, I will shift to the next speaker.
Yeah, that's all.
Okay. Thank you, Dr. Sharna. Excellent description by you. Thank you. Then I'm coming to Dr. Manoj Khandelwal. Manoj, as we have started the discussion about the vildagliptin, and I'm sure that we Indians are actually fond of using various combinations, and Verify also established the use of combinations. So now we have various combinations of vildagliptin. We have vildagliptin alone, vildagliptin 100 OD now is available. The vildagliptin with metformin in different doses like 50, 1000, that is available. And recently, vildagliptin with remogliflozin is also available. So various combinations of vildagliptin we are seeing. So what are your take about these combinations, and when and how we should use those combinations? That will be clinically relevant. Dr. Manoj, over to you.
So, good evening, all of you. And thank you, this team, to invite me for this wonderful session. And now your question is like, all you know, like type 2 diabetes is a progressive disease. Initially, when diabetes is diagnosed, initially at the time of the diagnosis, around 50% beta cell function is already lost. So generally, initial, already you told that we initiate from metformin, then we add another agent, but this verified trial changed the concept. Like initially, we have to start with early combination therapy, whether the HbA1c is 7 or 7.5, because it doesn't cause hypoglycemia. Because always we have scare of hypoglycemia, that whether we should use early combination therapy or not. But this verified trial changed this concept. So all we know, generally we get the patient like they are already on metformin therapy, they are in combination therapy, like they are already on sulfonylurea with metformin, or in various combination, they are taking insulin. So we want to know like whether we have to use it with vildagliptin with this molecule, or if there is any harm if we shift, if we add vildagliptin with this molecule. So we will discuss one by one. First, I will tell you about the sulfonylurea. All you know, like in Indian scenario, generally the mostly patient come with metformin with sulfonylurea. So in those category of the patient, because sulfonylurea always cause, there is the high risk of the hypoglycemia, and second, it causes slightly weight gain. So with if we add vildagliptin or other DPP4 inhibitor with this molecule, so it there are three benefits. First, it is weight neutral agent. It doesn't cause weight gain as like glimepiride. Second, if we add this molecule with glimepiride, there is very minimal risk of the hypoglycemia with this molecule, because the action of DPP4 inhibitor is like it causes increased insulin secretion according to the glucose level in the blood. If there is a high blood glucose level, then it causes increased insulin secretion. And third, it also causes like there is always risk of with the glimepiride molecule tolerability. With this molecule, this is well tolerable drug, so we can use this agent with sulfonylurea freely. Second, if we talk about like if the patient is on the insulin, we know with insulin there is always risk of the hypoglycemia and weight gain. But with this molecule, there is no risk of the hypoglycemia, and also there is no risk of the weight gain. So with we can add this agent with insulin therapy patients also. Third, the most important molecule which we are using in these days, which is SGLT2 inhibitor, because there are 2 or 3 molecules like SGLT2 with they are already in market. There is the combination with SGLT2 inhibitor, which is the like if there is the molecule Glixambit, Tangio, which is the molecule they add. There is the like empagliflozin with linagliptin combination therapy. So the trial has been done with this molecule already, because they have complementary action to each other. If we use SGLT2 inhibitor with vildagliptin, they have complementary action. How this complementary action? Like first, they act at different levels, because diabetes is a multiple pathophysiological defect. So these two molecules act at different level of the pathophysiological mechanism. So it just doesn't cause the, it just not only blood glucose control, but also it addressed the core defect of the diabetes. So this is very important that we can use SGLT2 inhibitor with this DPP4 inhibitor. So they address multiple pathophysiological defects. They have high efficacy. If we use these two molecules each other in combination, then it causes higher efficacy as compared to the if we use single agent. And third, it doesn't cause hypoglycemia risk. And fourth, most important part, like SGLT2 inhibitor, which causes genitourinary tract infection. But if we add with DPP4 inhibitor, the genitourinary tract infection risk is decreased. Why? Because generally most of the bacteria which like they have the DPP4 enzyme in their cell wall, but due to the DPP4 inhibition, these bacteria and these fungi are destroyed. So the urinary tract infection risk is also decreased with this if we combined both agent. So I think they have very good molecule if we use in combination therapy. So I think this DPP4 inhibitor can be used with any oral hypoglycemic agent, whether it is sulfonylurea, whether it is pioglitazone, whether it is insulin or SGLT2 inhibitor. Just not only amplify the action of the other molecule, but also it has specific like there is the specific mechanism which causes improvement in the function in the body. And important thing is like DPP4 inhibitor we use in the patient, it also causes decreased proteinuria. So this has a multiple action with DPP4 inhibitor, and we can use safely in our patient with other oral hypoglycemic agents.
Thank you, Manoj. Very, very well. So Manoj tried to describe that sulfonylurea or the SGLT2 inhibitors or insulin or any other medication can be safely used with DPP4 inhibitors like vildagliptin because of various benefits as he mentioned. But you have to select according to the patient's profile or patient's situation or patient different spectrum of other comorbidities or requirements. Like if the patient is obese, then this is definitely better to use with SGLT2 inhibitors. If the patient is lean and thin, is sick, then it is always better to start with insulin. If the patient is non-affordable, then this is always better to start with the sulfonylurea sort of medications. But according to the different patient profile, requirement and situations, you can take your decision. But this is among those molecules which can be added on to any of the combinations available. Dr. Manoj, would you like to add some more points about the vildagliptin OD that is now available? Would you like to add on some points?
There are some company who are launching this molecule, vildagliptin OD. So I think like generally there is always barrier when we use twice daily therapy or if multiple drugs we are using in the patient, because there is always compliance issue in our patient if we use twice daily therapy as compared to once daily therapy. So this was there was a problem with vildagliptin that we are using twice daily therapy with this molecule. But in the market, like if you know some molecule, like they are launching this once daily therapy. If we add once daily, then patient compliance is good. Also, there is well tolerable drug, so it can be used, and there is very less risk of the hypoglycemia with this molecule. So we can use this molecule once daily therapy also.
So in those patients who are already bombarded with a lot of polypharmacy, taking a lot of medications, because diabetes, we know that there are a lot more other comorbidities, and many times even for diabetes only, we need to add a lot of medications because of the poor glycemic status or control. So in those patients, definitely the less number of medications will be a welcome response, and that will definitely going to increase the compliance. So from the initial days of DPP4 introduction, when the vildagliptin was available, that was one of the most preferred molecule and because of the efficacy, safety, and other parameters which we have already discussed. But there were some ease on the vildagliptin by the other DPP4 because of the compliance issues, because the cost was not an matter in those days. But now the cost is definitely one extra advantage with vildagliptin, because now this is quite easily affordable, and the affordability is definitely a very important issue in India, particularly in city like ours or tier 2 or tier 3 cities where affordability is definitely an issue and most of the patient has the problems. And affordability, the compliance is again very important. So very well mentioned, Dr. Manoj, about these various aspects of use of vildagliptin with combination therapy. So now I will come to Dr. Pradeep, who is working at Moni Lake, and we know that Moni Lake is very good hospital in terms of dealing with nephrology patients. Their nephrology department is quite well known, 4 years together. And I'm sure that he is also having huge experience of dealing with the nephrology patient as he is practicing there. So my question to Dr. Pradeep is that we know that we are having a huge number of diabetic patients who are either having various stages of CKD or DKD, and many of them might be having ESRD or like stage 4 or stage 5 CKD. So in those patients, what is your take about the use of vildagliptin, how we should use, in which dosage we should use, and how that is clinically important and relevant? Over to you, Dr. Pradeep. Dr. Pradeep, you have to unmute yourself.
Sorry. Yeah, thank you, Dr. Balram, for giving me opportunity to share my experience regarding the use of vildagliptin in CKD patients, especially with mild, moderate, or severe renal impairment. Since the vildagliptin is absorbed within 3 hours and excreted mainly through kidney, but metabolized through liver, we can safely use the vildagliptin in mild cases of renal impairment. But in the cases of moderate to severe renal impairment, we have to decrease the dose of vildagliptin, that is up to 50 milligram per day. And in the case of liver impairment, that is patients with the increased level of SGOT and PT more than 3 times, we do not have to use this drug. And since the kidney patients have a decreased excretion, there is more risk of hypoglycemia with the use of this drug. But in my personal experience, I am using vildagliptin more frequently than any other drug in the kidney patient, apart from insulin, because insulin is the most safest, but the persons are refuses to take insulin dosage, or they are requesting for advising some oral medicines. So vildagliptin is one of the safest, not safest, one of the option available for use in kidney patients in cases of mild renal impairment. But in the cases of moderate to severe renal impairment, we have to decrease the dose. Definitely, it's 50 milligram per day. That is.
So in terms of GFR, would you like to add a few more points?
Yeah, in the case of a mild to moderate, that is, if the patients have up to estimated GFR is 60, we can safely use. But in the case of 30 to 60, we have to, in case of up to 60, we have to clearly use this one vildagliptin, that is mild renal impairment. But below 60 estimated GFR, we have to cautiously use the vildagliptin. That is, the dose of vildagliptin is up to 50 milligram per day.
And below 30?
Yeah, it's the same. But in the case of severe renal impairment, we do not, if we do not use vildagliptin, it's more safer, because there is a more chances of hypoglycemia in the case of severe renal impairment.
And at the same time, because in the renal patient, the chances of heart failure are also more, because kidney patient or the DKD patient might also be suffering with the heart failure chances. And in any patient who is at risk or in the stage of NYHA 3 or 4, then DPP4 inhibitor, whatever the DPP4 is, they are not best of the choice to be added on if the patient is having the risk of heart failure or he is already in that stage of heart failure. So in that stage of DKD or CKD, like when the GFR is less than 30, in my own experience, most of them are prone for the heart failure incidences also. But if that is not there, then you can use vildagliptin also in reduced doses, as mentioned by Dr. Pradeep. So he has included the renal part, he has included the hepatic part also, that once the SGOT-PT are more than 3 times elevated, then you should avoid using them. But Dr. Pradeep, would you like to add a few more points about the use of vildagliptin or the data about the vildagliptin in NASH patient, means NAFLD patients?
Pardon? Any
NAFLD patient.
Acha, non-alcoholic. I have not much experience regarding this one, but the patients with the, because NAFLD patients have raised levels of SGOT-PT, so we have to generally first go for the testing for these tests. If the level is more than 3, then we have to avoid. But I think practically, if the patients have raised level of transaminase, then we have to avoid this drug. In my personal experience, but I do not have data regarding.
Okay, no problem. Dr. Manoj, would you like to add?
So in liver disease, generally already told by Dr. Pradeep that it is metabolized by the liver. So generally, if the liver enzyme, if it is more than 3 times raised, it should be contraindicated. Like it is contraindicated drug if the liver enzyme SGOT-PT is more than 3 times raised. But if the patient who has liver disease, who is stable liver disease, then it can be safely used up to the 2 times of the liver enzyme. If it is raised, then it can be used. So in NAFLD patient, it can be used if the liver enzyme is less than 2 times is raised. But liver disease should be stable. This should be kept in mind.
Yeah. So in established CLD patient, one should avoid using these molecules. But there is some data available that in NAFLD patient, because NAFLD is quite common, fatty liver is very common, even in those patients who are non-alcoholic or the alcohol is up to the permissible limits. In diabetes itself, the NAFLD is pretty common entity. And there is some data that not in the advanced stages of liver disease, but in the initial stage of liver disease, like the SGOT-PT are less than up to 2 times elevated, then there is data that DPP-4 inhibitor might be beneficial in the NASH patient or NAFLD patient in reducing the burden of NAFLD also. Although these are the preliminary data, and still we need more solid proof to be used these molecules to treat the NAFLD by themselves, but they are still not available. But we can say that in milder cases of NAFLD or fatty liver, there is some data that the DPP-4 inhibitors, including vildagliptin, might be useful in reducing the burden. So thank you, Pradeep, and thank you, Manoj, for your views about this clinically important point. Now, I'm coming to Dr. Ashok Garg. And Dr. Ashok, are you there? Dr. Ashok is practicing cardiologist and physician in the Jaipur Heart Institute. And I'm sure that a lot of elderly patients are coming to your institute as well, because you are dealing with cardiac patient, and most of them are elderly, although younger cardiac patient are also not uncommon these days. But what are your take about the use of vildagliptin or DPP-4 inhibitors in elderly population? Elderly means more than 65 or so.
Good evening, respected seniors and my dear friends. I'm going to talk about the vildagliptin use in elderly patients. As all of you know, that the most commonly used anti-diabetic drugs in present scenario are the sulfonylureas and the metformin. But there are some shortcomings, especially in the elderly population. If we talk of metformin, sometimes it is causing GI intolerance, and somewhere it's contraindicated, like in advanced renal disease. If we talk of sulfonylureas, it causing severe hypoglycemia. So to overcome all these things, we use vildagliptin. The beauty of this molecule vildagliptin is it's well tolerated. That is unlike metformin. It's weight neutral, unlike sulfonylureas, and it is free of hypoglycemia, and that is the most serious side effect of sulfonylurea. it also, very important feature is, it also improves the beta cell health. That is the favorable beta health cell, and that has been proved by improvement in the markers of beta health cell function like HOMA, insulin proinsulin ratio. It's also noted. Also, it appears to improve the alpha cell sensitivity to glucose. The vildagliptin enhances the glucose-dependent insulin secretion from the pancreatic beta cells. That's why there is very low rates of hypoglycemia, and glucose. It also glucose-dependent suppression of the glucagon release from the pancreatic alpha cells. The vildagliptin, initially it was proved to be inferior to the other oral hypoglycemic drugs in terms of the CV morbidity and mortality, but later on, the DPP-4 inhibitors have been shown to be the protective effects in terms of the cardiovascular morbidity and morbidity. The other point in favor of vildagliptin use is that it lowers the HbA1c level, fasting blood glucose level, as well as the postprandial glucose level. The vildagliptin can also be used in patients who require intensification of existing sulfonylurea therapy, in whom the metformin is contraindicated or not tolerated. Next, if we come to Ramadan, in Ramadan, the studies conducted in Muslim community demonstrated that vildagliptin was associated with significant lower risk of hypoglycemia during fasting compared to the sulfonylurea. And in the last and most important factor is cost and compliance. Previously, say 1 or 2 years back, the problem with DPP-4 inhibitor, including vildagliptin, was its cost. But nowadays, it's available almost in the cost of metformin or sulfonylurea. That is the minimum cost. And if we talk of the compliance, so the compliance will also be excellent, and it is available, cheap, and nowadays, as already Dr. Balram has said, the sustained release preparation are also available in the market. So this is again in favor of using the vildagliptin. So looking at all these unique features of vildagliptin, I consider it's a unique molecule to use in diabetic population.
Very well narrated, Dr. Ashok. As we know that, as Dr. Ashok highlighted the importance of those medicine which are safe in terms of hypoglycemia, which are affordable, which are easy to use. They are always the best of the molecules to be used in the elderly population, because we know the various challenges of elderly population. They are not that compliant to the medication. They are not affordable, means many of them are not affordable if they are not having the pension facility or the family support mechanism. Many of the elderly are living in alone. And if there is a development of hypoglycemia, that might be devastating in that particular population. That might be really dangerous, and they may land into the coma or vegetative state. I have seen, and I'm sure that all of you might have the experience of treating those patients who landed into hypoglycemia because they were living alone. They were on the sulfonylureas, particularly in the era of that glibenclamide sort of medication. Dr. Sarna might be having more experience of that medication. I have seen in my PG days that the patient landed into the emergency with the coma, and later on they never recovered from that particular stage of hypoglycemia because they landed into the vegetative state. So that might be really dangerous, because the reflexes are poor, the response rate is poor, they are not friendly to the mobile phones also, they might not be having access to these communication methods. They might be living alone, they might be living at distant places. The family or the kids are either settled at other town or other metros, and they are living here, or even in these smaller towns there might be there. Affordability definitely is one problem. So those molecule which does not causes hypoglycemia, the molecule which is easy to afford now because of these problems, that will be really excellent. And if that is safe also, like tolerable, that is not causing GI side effect, that is not causing weight loss, that is not causing hypoglycemias, that is affordable. So that would be excellent molecule to be used. And that's why the DPP-4 inhibitors are among the best of the medications available to treat this elderly population. The other good molecule of today's era, like SGLT2 inhibitors, might not be that good in elderly population. I want to clarify here also, because in few patients, particularly in elderly population, we are commonly seeing these problems that doctor, once you have prescribed this molecule, I am facing the problem of weakness, significant weakness. I'm not feeling well after starting of these molecules. And these problems are more frequently from the elderly population. I'm sure that all of you might be agree with me. In younger population, the tolerance of SGLT2 is far better than in the elderly lean thin population. Although in elderly obese, you can use it and you can try. If that is tolerable, then you can continue because they have various other benefits. But in few patients, that might be problem. But that is not with DPP-4 inhibitors. So thank you, Dr. Ashok, for enlightening our audience with your views about the utilities and safety in Ramadan patient, in elderly population. So in last, I would like to say that before the era of patent, we know that before that era, every molecule was costing more than 50 rupees. And that was the molecule of the affluent class only. And before prescribing, particularly I can say, or I can share my experience, that I was always asking to my patient, Docs, Baba, ek mehengi dawai hai, aap le loge kya? That type of problems we were facing. And many times the patient was agree, okay, you can start with, but on next month he is coming, Doc Saab, iski jagah kuch aur likh sakte ho kya? So that was very common entity which we were seeing, and still we are having few molecules which are still in that range of cost. So the same amount of benefit, the same amount of efficacy, the same amount of safety, if that is available in the affordable range, affordable up to the tune of 10 rupees, 15 rupees or so, then why we shouldn't use that molecule and why we shouldn't pass on the benefit to the patient? Yes, and now I don't have to ask my patient that Baba, main mehengi dawai likh raha hu, can I start with? So these type of situations might not be there, and that is more common in a hospital like SMS. Manoj is smiling because he is practicing at Fortis Hospital. So he might be seeing more affluent class of patient, but I have to definitely deal both with those patients. So I have to definitely deal with those patients where the affordability is definitely very, very important. Fine. And this is really a respite and relief to the clinicians like me who are practicing in government sector, where I have to deal not only with the higher class, but also with the poorest of the segment of our society. So that is really excellent if we are able to have those molecules which were available few years back in the range of 50 rupees or more. And the overall cost of therapy was nearly 4,000 or more per month. And now that is affordable in the range of 1,000 to 2,000 per month. So that is really pretty soothing to me. And I'm sure that all of the clinicians are agree with this particular step of the industry, that they have provided us now with various options available, various good company, various good molecules are available now with OD formulations also. So if any of you want to add a few more point or something that is there in your mind you want to share, I invite you to share, and otherwise we will hand over the session to the organizers. Thank you, all of you.
Ram.
And Dr. Balram?
Yes, Dr. Mukesh, please.
I just want to ask about your experience about the potency and difference amongst the other DPP-4s, like vildagliptin in comparison to teneligliptin, linagliptin. What is your take about the difference and potency or the utility of, like, in similar range that this was earlier costlier, in similar range the teneligliptin is available. Do you find this teneligliptin comparable to vildagliptin?
Actually, I can share my clinical inputs only because exactly the data is not available, head-to-head comparison data is not available. But what I can say that teneligliptin, although I was using but not with that confidence which I was able to use the other DPP4 inhibitors. And the sole component of using the teneligliptin was with the availability of whatever data we do have. We know that Korean data, we know the Japanese data, and few Indian data also. But the main thing was the affordability issue. And only in those segment of the patient where I know that the affordability is definitely a problem and I cannot prescribe the trusted molecule, then I have to use those molecules. Otherwise, in those segment of the patient where affordability was not a matter and the patient was agree that, okay, no problem, doctor, then I was, of course, preferring those molecules which are time tested. In my own experience, I can say that Denali is also efficacious. I can't say that is not efficacious. That is okay. Although head-to-head, I won't like to comment. But the vildagliptin BID is as good as sitagliptin OD or the linagliptin OD. Saxagliptin I have least experience. In the initial days I was using, but later on, I'm sure that all of you are also not using that frequently with saxagliptin. So Saxa experience is least, while the linagliptin, sitagliptin, vildagliptin, I have used experience and I have no hesitation in sharing that all of these molecules are almost equally efficacious. Although there is a little difference between these molecules in terms of the CVOT data or the safety data. Although Vilda don't have any CVOT with us, but now the FDA also says that CVOT is not required for any molecule to be introduced. And there are various discussion about the pros and cons of CVOTs also. But as the experience with vildagliptin is used in our own population, I have experience of using vildagliptin in thousands of patients. I'm sure that this similar is with every clinician here in India. So we can say that this is quite safe molecule. Only we should take care about those Lakshman Rekhas, that we should not cross those lines. Like in heart failure patient, we shouldn't use any DPP4. The similar is with sitagliptin, similar is with linagliptin, similar is with teneli or this vildagliptin. And as Dr. Pradeep mentioned about the ESRD patient also. Otherwise, these molecules are excellent. And there is no fun of using those molecules which are definitely costly. And if the affordability, as I know that in 80% of the population, affordability definitely matters, or even 90% of the patient population, affordability matters. So there is no fun of using other costly DPP4 inhibitors once we have the vildagliptin with affordable range and the quality molecules is also available with us. That's all from my side, Dr. Sarna.
Thank you, Dr. Balram.
Okay, thank you, sir.
So thank you, all of you. Thank you, Dr. Sarna. Thank you, Dr. Ashok. Thank you, Dr. Pradeep. Thank you, Dr. Manoj. Please take care of yourself because we are passing through a really difficult patch of the time. And everybody of us was actually cursing the 2020, that this was the worst of the year. But now we are seeing that 2020 was even better.
2021 is more worse than
2021 is far worse than the previous year. So take care of yourself, take a lot of care of your family also, because this is really tough time. Many of the doctors are infecting again and again. Over to you, Rakesh.
Yeah.
Fighting all of us.
Yeah, please allow me to share with you some data, only one slide, wherein I will talk about one data with vildagliptin.
Yeah,
and
you can.
And then also allow me to talk about one very important presentation, sir. That will take hardly 2-3 minutes, Yeah. So.
Yeah, Rakesh.
Yeah, thank you very much, sir. I just share my screen,
Although I think that most of the aspect has already been discussed, so I think your presentation will be crispy and short.
So I am not able to share my screen, so I will just go through the slide because I will just talk about.
Only salient point you can share here.
Yeah, thank you very much, sir. So, sir, let me take this opportunity to introduce first time in the world once daily vildagliptin from Alkem in the management of diabetes. The brand name is Gluvilda OD, which is vildagliptin 100 mg sustained release tablets for good control in diabetes, and which ensures glucose control with vildagliptin. Sir, the important point is like mean DPP4 inhibition. It is found that 85.2% with vildagliptin sustained release versus 86.8% with innovator brand 50 mg BID. And this one more point, sir, bicovalent to the innovator brand 50 mg BID. And second point is that 84% DPP4 inhibition over 24 hours with vildagliptin sustained release, which we are offering in once-a-day doses at par with the innovator brand 50 mg BID. So this is one study we have, sir. If you require, we can give it in hard copies also. And Gluvilda, I spoke about the brand also. If you talk about the affordability, this is the very least price, sir, as compared to any other brand which is launched in the market, sir. This is what I can share with you, sir. Yeah. And
Very good.
thank you. Other than this, sir.
So I think every point has been discussed now, so we can conclude the sessions now.
Yeah, sir. Just 1 minute, sir. Please, I will not take much time. Sir, this is regarding, this is Connect to Clinic, sir. This is a 100% medico legally compliant virtual clinic with doctor-patient engagement platform. C2C is the name. And this is, sir, wherein we have compliant with latest teleconsultation guidelines of NFC, international standards of HIPAA high-tech infrastructure of data safety and security, quick access to consolidated patient history, and ensure speedy payment without follow-up. In 24 hours, payment is there, and intuitive and flexible scheduling, and 24/7 customer support. And this is, I'm talking about Connect to Clinic, sir, and also, like, as you know, applications which have like WhatsApp kind of thing, wherein bank account and card details are at risk, location data, contacts and pictures also being shared, anybody can access, diagnostic logs, interaction with patient. So these are some of the limitations. If we compare Connect to Clinic with others like online platforms like Practo, Liberate, Dovcon, 24/7, we have got many features wherein we are doing good, better than other features, sir, like patient counseling, service charge, wherein 6% is there with Connect to Clinic, others are 20%, 10% or more than that service charge. Payment within 24 hours, whereas others like Practo, Liberate, their payment is takes 7 to 8 days time. Complimentary promotion from company, like a lot of features are there that we can share, my colleagues can share with you when they meet you in person. And this is not a marketplace, this is a virtual platform wherein individually we are, doctor can access. So
yeah, that is clinically really relevant, particularly during these days of COVID, when most of us are not willing to continue with the clinics.
Absolutely, sir. And the current era, if you see, this is, last year, it is, very difficult, as you just were sharing among each other, sir. So this is C2C is something which is absolutely different. Abhi slide mein show karna difficult hai, but 1-to-1 we can come in, our colleagues can come in and share with you, sir.
Yeah, definitely.
And now, not taking much time, another just 1 minute, I would like to take this opportunity to thank Dr. Balram Sharma, sir, for moderating the panel discussion, all the panelists for sharing their views on vildagliptin in clinical practice. And we'd also like to thank all the doctors, those who have joined us for this panel discussion. And I'm sure you will appreciate the views on vildagliptin presented today. We salute, sir, as Alchemites, all our doctors, paramedics who have contributed immensely for keeping us all safe and healthy in these challenging times. And we at Alchem Laboratories will continue to serve doctors and patients by making our products available, like some of the big brands, sir, Allchem, Gipirose, Gluvilda M. And with this, sir, I thank you very much, all of you, sir, for giving a valuable time, sparing your valuable time with us. Thank you very much, sir. And have a great day, sir. That's it.
Thank you, sir. Thank you very much, sir.
Thank you,
For your
everybody.
valuable time, sir, and presence. Thank you, sir.
Yeah, welcome, everybody.
Thanks, sir.
Thank you.
Okay, Vinod.